Hello, welcome to our webinar number 3 of 2023. I want to welcome you all. I'm Pat Sullivan, the CEO and co-founder of the Heart Brothers. I just want to thank you all for joining us, especially all our volunteer speakers and all the support you've given us. And we hope you'll learn an awful lot tonight from expert people on several subjects. And with that, I just want to turn it over to Mr. Webinar, Hamid Madavi. Thank you.
Thank you, Pat. You're too kind. So welcome, everyone. Thanks for joining another one of our webinars. This is the third in a series of webinars. Let me share my screen here for a moment, and we will get on the program. Okay, so our webinar tonight is heart failure awareness. It's the third in a series of webinars. It's end-stage mitigation, particularly heart transplant and how heart transplant interplays with organ donation. Before we get started, some Zoom best practices. Please maximize your screen so you can see the entire show. For comments and feedback, please put it in chat. And for questions, please put it in the Q&A session tab. We will have time at the end to answer some of your questions, and so just let us know what your questions are. Just a couple reminders for those of us who don't, of you who don't know us. We're Team Heart Brothers. We're patients just like you. We've all had, most of us have had a heart transplant. We've traveled the heart transplant journey, and after our transplant, we've decided to give back to the heart failure community. We're all volunteers, and we are trying to help all of you out. Our mission is to help and support heart failure patients and their loved ones navigate a life with heart failure and all its challenges. So just a quick update of what our various events and initiatives are. So every month, we have a patient support group. It's the second Thursday of the month at 6 p.m. We have discussions there among patients, share our stories, share our challenges, our goods, bads, ask questions, and then if there's an interest on anything in specific that there's a consensus you want to hear about, we will bring in a subject matter expert to speak to the group on that. We have been working on a heart failure awareness campaign. As I mentioned, this is the third in the webinar. We had webinar 1, which was heart failure awareness, the basics. What is heart failure, symptom management and treatment? What are out there? Webinar 2, we spoke about heart failure risk factors, how to mitigate your risks, and lifestyle changes. And also, we had some interesting discussions on navigating insurance issues and what insurance companies are doing to help their heart failure patients and how you can maximize that benefit. So the webinar today, we have some very most excellent people that are going to talk about heart failure awareness, the end stage mitigation, which is pretty much heart transplant and organ donation. This is April is organ donation month, so we're doing that jointly with New England Donor Services. And then after that, the fourth element, which will be happening early May, is we have a heart failure awareness 5K run walk that helps us raise funds so we can provide help and assistance to patients who have heart failure. So I also want to take a moment and thank our sponsors, Cytokinetics, Transmedics Corporation, and CareDx. Just a little information, what we share on this webinar, while offered by medical professionals, they may not be directly applicable to your specific condition. Please, please, please consult your physician and treatment center regarding what approach and strategy is best for your specific condition. Do not change your treatment regimen based on the information provided here. and those of you who need resources, if you go either for the Heart Brothers House or all the things that Heart Brothers does, just go to heartbrothers.org. We have a number of pull-down menus and pretty much anything that we offer, from previously recorded webinars to any and all other information is available there for you. And I wanted to take a moment and encourage you, if you haven't, to sign up to support our Heart Brothers 5K Run Walk. It's going to be between May 7th through 13th. In that period, you have to either run or walk 5K, which makes it really easy for somebody like me. So you can either form a team, recruit your supporters, and run walk to fundraise Heart Brothers, or you can make a donation and support one of our already existing teams. Many of the area hospitals have teams, many of us have teams. Any and all donations are welcome. Just go to heartbrothers.org, event 5K run walk, and follow the instructions. Thank you. And with that, let me introduce our excellent moderator, Linda Ordway. Linda is an acute care nurse practitioner at Tufts Medical Center and has worked in the advanced heart failure program for over 20 years. Her passion is caring for patients with heart failure while in the hospital setting, who are critically ill and just learning about their heart failure illness or the progression of their illness to required advanced therapies. She was instrumental in developing the Cardiomyopathy Center at Tufts with the goal of providing the most expert care, education, and support for patients and caregivers with advanced heart failure. She serves on the board of directors of the American Heart Association of Heart Failure Nurses, providing leadership and education to the heart failure patients. With that, Linda, take it away. It's yours.
Mead, thank you so much. Thank you for the invitation to be here and be a part of this. And thank you for that kind introduction. It is my pleasure tonight to introduce our two speakers, and I'll moderate the session. You can put your questions for each speaker in the chat, and we'll have question and answer period afterwards. And I will take your questions from there at any time before, during the program or afterwards as well. So our first speaker is Dr. Giverts, Dr. Michael Giverts. He is the medical director of the Heart Transplant and Mechanical Circulatory Support Program at Brigham and Women's Hospital and professor of medicine at Harvard Medical School. Dr. Giverts is extremely well known in Boston as well as nationally, and has an extensive bio, including extensive research, publications, and experience managing patients with advanced heart failure and therapies to support them. Dr. Giverts will be speaking to us about heart transplant, how the evaluation works, as well as success rates and survival rates, and things about surgery. So without further ado, Dr. Giverts.
Great. Thank you so much, Linda, for the kind introduction. And I want to thank Hamid and Pat for giving the opportunity really to join everyone really this evening to really talk about something that I am truly passionate about and have been passionate about really since I was a medical student. Actually, heart failure was really the first patient I ever took care of as a medical student had heart failure, and I've loved caring for patients with heart failure ever since and helping them get to advanced therapies, including heart transplantation. So I'm going to share my slides and talk a little bit about the field, where we've come from, where we are currently, and a little bit about where we're going, just to kind of keep things novel here. So I will share my screen, and can you see my first slide? Okay, great. So, so I'm going to start with this slide, and just really the message that for most of the patients that I take care of with heart failure. Heart failure is a progressive disease. And I hope you don't mind me showing some true anatomy here, because I think it is illustrative. So on the left here, this is actually a normal adult human heart. And on the right is a heart that was removed from a young physician, actually, who had end-stage heart failure from a viral cardiomyopathy, who had a successful heart transplantation many years ago. And this process by which a normal adult human heart progresses to more of an advanced or end-stage heart failure is called remodeling. And this process typically takes place over months and years, during which we take care of patients and get to know them and their families extremely well before we even begin to think about things such as heart transplantation. Now, the good news is that we do have medical therapies and device therapies that help this process go in reverse. A process we call reverse remodeling, but for, unfortunately, some patients, it's a progressive process. Now, when we evaluate patients in the office or in the hospital who come to us with a diagnosis of heart failure, some people use the term congestive heart failure, which is older terminology, and even heart failure, although it's the current terminology, many of us in the field don't like it as a term. Your heart hasn't failed you, but it is what the condition is called. And so when we see patients, we're looking for some of these signs. Some of them are obvious, some of them are more subtle, of advanced heart failure, in which we may want to be considering advanced therapies, including heart transplantation. So we now have excellent medications to treat heart failure, but at some point, some patients will become intolerant to the standard medications we prescribe to treat heart failure. Patients will often be on diuretics or fluid pills, but over time may require higher doses of diuretics or combination diuretics. For many patients with heart failure, it's the left side of the heart, the main pumping chamber or the left ventricle that fails. But over time, the right side of the heart that pumps blood through the lungs can also begin to fail. Again, another sign of advanced heart disease. Now, for many patients with early heart failure, weight gain and fluid retention is the main problem. But for patients with more advanced disease, we begin to see other signs such as malnutrition and weight loss, and even frailty in some of our older patients. Of course, the clinical manifestation of all of these and other factors is recurrent hospitalizations. We just can't keep the patients out of the hospital. They keep coming back with recurrent or worsening heart failure, and often associated with worsening of other organ function, including kidney function, liver function, and other organ systems that we'll briefly mention in thinking about our evaluations of patients for heart transplant. Now, what is the survival like of patients who do develop advanced heart failure? And I think for many patients and their families, this is very surprising information. You don't hear a lot about heart failure in the press and in the news, whereas you may hear a lot more about heart attacks and strokes and even various forms of cancer. And what I've shown you here is the 1-year mortality rate associated with these diagnoses. And these are averages. This is not for all patients. But what is most remarkable is that patients with advanced heart failure who have those signs and symptoms and repeated hospitalizations, they can have a 1-year mortality of nearly 50%, whereas patients after a heart attack, the mortality rate after 1 year is only 20%. It's only 10% a year after a stroke, and only 7% after being diagnosed with colon cancer. And even metastatic cancer has much greater survival than that associated with advanced heart disease. Well, let's talk a little bit about organ transplantation. And I think to understand where we are currently, you need to have a little bit of an understanding of where we've come from. And I just show you this photograph. This is taken in Moscow, Russia in 1958. And this gentleman sitting here on the bench with his German Shepherd is a Russian surgeon by the name of Vladimir Demikov. And Dr. Demikov was really a pioneer in developing the technique of organ transplantation. And During the 1940s and 1950s, he performed more than 250 heart transplants using numerous different surgical techniques. And I apologize if there are animal lovers. I have a dog myself, but these experiments were done in dogs primarily. And some of his dogs did survive months and longer. Interestingly enough, none of this data was known about in the West. In fact, none of his experimental data was published until 1962. And by then, many things were going on around the world leading up to the really landmark or seminal event which occurred in 1967. So over 50 years ago in Cape Town, South Africa, the surgeon shown here on the right, Dr. Christian Barnard, performed the first human heart transplantation. And here he is shaking the hand of his first patient. This was a middle-aged man with diabetes and end-stage heart failure from heart attacks, who received a donor heart from a young woman who was killed in a motor vehicle accident and was in the operating room next door, where they took the heart and transplanted it into this first patient. Now, unfortunately, this first patient did die about a week and a half after this picture was taken of infection, but Dr. Barnard's second patient, who was transplanted a couple of months later, did live almost 2 years and really got the field going. And in fact, Dr. Barnard did get all of the press at the time for performing this incredible landmark surgery. But it was really Dr. Shumway and Dr. Lauer, so Norman Shumway shown here on the left and Richard Lauer, his assistant on the right, who really developed and grew the field of heart transplantation at Stanford University in California. And this got things going in the United States and around the world. Now, they persisted despite the fact that initially things didn't go so well. And in fact, in 1971, only 4 years after the first heart transplantation occurred, this was the cover of Life magazine, the tragic record of heart transplants. Groups of surgeons and cardiologists and ethicists were calling for a moratorium on the performance of heart transplantation because patients did not do well. But Dr. Shumway and his colleagues at Stanford and other centers persisted. This photograph was taken actually off the coast of Maine in 1978, so about 9 years after the first transplant occurred. And this is on the cover of a book that was written by a woman named Victoria Poole. The young man shown in this photograph's name was Sam Poole. Sam actually grew up around the corner from me in Portland, Maine. And when Sam was in high school, he developed heart failure from what was thought to be a viral-associated or viral-mediated cardiomyopathy. And Sam was one of the first 100 patients who was taken to Stanford and underwent heart transplantation. And he did well for several years. And this is a photograph of Sam jumping off one of his family's boats on the coast of Maine. And at the time, Sam said, the stronger the pain gets, the more you learn to handle it. You just adjust. Well, these pioneers persisted, and you can see what happened with heart transplant volume around the world. So in the 70s and early 1980s, there were virtually very few transplants occurring. But in 1981 and 1982, cyclosporin was introduced. And with the introduction of cyclosporin on top of prednisone and an older immunosuppressive medication called azathioprine, the outcomes improved dramatically, and the numbers of transplants that were performed and the number of centers that performed transplants increased dramatically until the early 90s, when the numbers really leveled off to around 4,500 transplants per year around the world. And similarly, we saw this in the United States as well. So this is looking at US heart transplant volume. And you can see here, this is from 2010 up until 2022. And again, in the early 2010s, things were pretty flat in the United States. About 2,200 heart transplants were performed each year. But over the last 8 to 10 years, there has been a steady and gradual increase. And in fact, in 2022, over 4,000 heart transplants were performed in the United States. Really, again, a wonderful achievement. And we'll come back to trying to understand the reason for that in just a minute or so. Now, as some of you may know, the United States is broken down into regions, and Craig may mention this a little bit as he works for Region 1. And Region 1 is New England. Shown here on the right is the number of heart transplants performed in each region in 2022, so the most recent data. And what you can see is that region 1, which is the smallest region geographically, also has the second smallest volume of heart transplants per year, about 200 transplants per year, whereas you can see, for example, region 5, which is over on the West Coast, including California, did over 700 heart transplants in 2022. And maybe folks may have questions about why there is this variability around the country. Now, just a couple of words about evaluating patients for heart transplant. Since many of those joining our call tonight may have already had a heart transplant, I didn't want to get into some of the nuts and bolts of how we actually evaluate and list a patient for transplant. I'm happy to try to answer those questions at the end. But when I think about evaluating a patient for heart transplant, there's really two questions that we really need to ask, and they're really shown here in a very simple Venn diagram. So the first is on the left in the red. Is the patient sick enough from a cardiac standpoint that they need organ replacement therapy with either a heart pump or a heart transplant? If the answer to that question is yes, if they meet many of the criteria that I mentioned previously with repeated hospitalizations and have developed end-stage heart disease, the evaluation itself is really to find out whether or not the rest of the mind and the body and the family and the support system is healthy enough to get the patient not only through the heart transplant, but to have them do well, not just in the first month or 6 months or year, but we want patients to go back into active lives and have excellent quality of life for years to come. And that's really the basics of an evaluation for heart transplantation. So again, we know a lot about the heart disease. We know the patient is sick enough. We then need to do an evaluation. We need to make sure the kidneys and the liver and the lungs and the brain are all healthy enough to get through an operation and to do well over the next several months and years. We also want to make sure that the patient in general has taken good care of themselves and they have a strong support system to get them through the tough times and to celebrate with them through the wonderful times. Well, I want to come back to this issue of increase in heart transplants in the last 8 to 10 years. As I said, we're now over 4,000 transplants. How did we get there? Well, you could say, unfortunately, one of the reasons is the opioid epidemic in this country, which is a real problem. This was an article that was published in the New York Times in 2016. It was entitled "As Drug Deaths Soar, a Silver Lining for Transplant Patients." And it said, from Boston, the surge in deaths from drug overdoses has become an unexpected lifeline for people waiting for organ transplants, turning tragedy for some into salvation for others. This photograph I've actually put here, this was not in the article. This photograph, some of you may recognize, is taken from the corner of Massachusetts Avenue and Melnia Cass Boulevard in Boston, so-called Mass and Cass, which unfortunately is the center of the opioid crisis in our city, and a huge problem that is almost impossible to solve because it's also complicated by other issues, other health issues, mental health illness, as well as homelessness. Well, I think it's important to celebrate the lives and to thank donors' families for making that gift of life. You'll hear more about that. This picture was taken last fall from the lawn in front of the old Peter Bent Brigham Hospital at 15 Francis Street. Again, each of these purple flags celebrates and honors the life of one opioid overdose death in 2021. Now, one of the things, again, in thinking about variability is the distribution of donor hearts. And you can see here the distribution of these hearts comes from all over the country, but there are areas of the country which have higher percentage of deaths that are due to, say, drug overdose and not due to, for example, trauma or motor vehicle accidents or other stroke or other unfortunate acute injuries. And you can see that there are hot spots in the country. You can see the Midwest here, Texas, California, Florida. It turns out that 1 in 6 of these organ donors are actually positive for hepatitis C. And I share this with you because this has been a landmark achievement and has helped us move forward tremendously with offering more organs to our sickest patients. And for many, many years, if a donor had hepatitis C, we were not able to use those otherwise healthy organs. But about 10 years ago, these medications, so-called direct-acting antiviral medications, I've just shown some pictures here, were approved by the FDA to treat and really cure hepatitis C in a very short period of time. And so we took this information, and Dr. Ann Woolley, you can see here on the left, and her colleagues, along with our group in the heart transplant and lung transplant team here at the Brigham and Women's Hospital, performed a landmark study called Donate HCV. This is Dr. Woolley presenting our data at the International Heart and Lung Transplant meetings in Nice, France in 2019, showing that one could safely use these donor organs and treat the infection so that recipients could do well and survive for months and years. And we showed that by instituting hepatitis C therapy along with immunosuppression, immediately following transplant, that the virus essentially went away within 2 weeks in all of our patients. And this has now become standard of care. And in fact, if you look as recently as 2020, 10% of the transplanted organs in this country are transplanted with hepatitis C, but we now have curative therapy. People also ask about, what about donors who were COVID positive? And we recently published this data as well, showing that the numbers of organs that come from donors who had COVID is now up to about 8 to 10%, and we can safely use hearts, kidneys, and livers from donors who had a COVID as a co-infection. Well, I want to spend a minute just also mentioning about advances in donor heart preservation and transport that's required to get the heart to the operating room to perform the procedure. And for more than 40 years, ice storage, shown here on the left, putting an organ in a cooler and carrying it either in an ambulance or on an airplane and then in ambulance, has been the way that transplant has been performed. But we now have newer techniques, such as this device in the middle here. This is so-called, it's called the Sherpa pack. This is a device in which the heart is packed in temperature controlled environment so that the heart is cooled but maintained at a very strict temperature. And then more recently, as shown here on the right, this is taking a heart and putting it on what we call, in what has been termed by some, the heart in the box, where the heart is actually perfused by warm blood during the period of transport and can be monitored prior to the time of organ transplantation. Well, what do outcomes look like post-transplant? Everyone wants to know, how am I going to do? How will my family member do after they receive an organ transplant? And the results are excellent, but we can always do better. And this is looking at survival over time periods post-transplant. So at 30 days, survival is about 95%. 1 year survival is 90%. 5 year survival is 75%. And over half of our patients are now living more than 10 years, if not many more years after that. And in fact, this picture was taken in Cambridge, England, just last year in 2022. The woman shown here in the middle is thought to be the longest living survivor of heart transplantation. She was transplanted in 1982, 40 years ago plus, by the surgeon shown here on the left. Now, she did have a second heart transplant that was performed in 2005 by the younger surgeon shown on the right. So she's lived more than 40 years with 2 heart transplants. And some patients have lived with the same heart now for more than 30 and 35 years. These results are tremendous. But problems, I think, as all of you may know, still exist. It's not a perfect procedure, and life with a heart transplant is not perfect either. And I just show you some examples. So coronary artery disease that develops in the transplanted heart, which is a form of chronic rejection, can lead to both symptomatic and silent heart attacks. Patients take many immunosuppressive medications every day, but despite that, they still can develop heart rejection and infection because of immunosuppression. And then our patients need to be monitored for skin cancers and other cancers as well due to chronic immunosuppression. Well, I want to end by just giving you a snapshot into the future, but to do that, we have to take again another quick look backward. These are photographs that were taken over 40 years ago at Loma Linda University in California. And on the left here is Dr. Leonard Lee Bailey, who was a heart surgeon, performing a heart transplantation on this infant named Baby Faye. And why did this make the news in 1984? Well, I think as some of you may remember, Baby Faye actually received the heart from a baboon. This was a first example of xenotransplantation. So taking a heart from one species and transplanting it into a patient. And in fact, this event was memorialized in Paul Simon's album, Graceland, in which he sang, "Medicine is magical and magical is art." Thinking of the boy in the bubble and the baby with the baboon heart. And he was thinking about Baby Faye. Well, fast forward to January of 2022, and this photograph was taken at the University of Maryland in Baltimore. And this is the surgical team led by Dr. Bartley Griffith performing the next human xenotransplantation, which a genetically modified heart from a pig was transplanted into this patient shown here in the middle, in between his son on the left and the other surgeon, and really the scientist behind the genetic modification, the development of this incredible achievement, Dr. Mahudin. Unfortunately, this patient lived only for several weeks, and it was discovered, and in this article by the New York Times, that perhaps one of the things that led to, unfortunately, the early death of this patient was the fact that a virus had traveled with the pig's heart into the patient. So unfortunately, this did not end well, but there is still a lot of work to do and a lot of hope remains in this area. So what is the future of heart transplantation? Well, I'll end with two quotes. The first is from J.K. Rowling, a British novelist, you all remember from the Harry Potter series. And J.K. Rowling said, "The consequences of our actions are so complicated, so diverse, that predicting the future is a very difficult business indeed." And so for me to sit here and try to predict where we'll be in 10 or 15 or 20 years would be virtually impossible. But I think a better quote, which I like to provide, is from one of my heroes, Mick Jagger, from the Rolling Stones, who said, "You can't always get what you want, but if you try sometimes, well, you might find you get what you need." And that, I think, is what we're doing for our patients and their families, and will continue to do for years to come. So I'll stop there, and I thank you very much for allowing me the opportunity. And I'll turn this back to Linda and Craig Tucker.
Thank you, Dr. Givitz. That was amazing. And you know, to live the history and see the history of where things started and how far we've come now is just incredible. And thank you so much for presenting about the outcomes as well, and helping people understand that this is a therapy that does work well for patients. We will entertain the questions for Dr. Givitz at the end of the discussion. Are you okay staying on for that time period, Dr. Givitz? Okay, thank you. So again, our next speaker is my pleasure to introduce, and our next speaker is Craig Tucker. Craig is a respiratory therapist and ECMO specialist in his past life, but more recently has had greater than 9 years experience in the organ procurement organization, and is currently director, New England Donor Services, Senior Director of Donation Strategy and overseeing hospital development and relations. And Craig is going to talk with us about organ procurement and things that are considered on the other side of the coin in getting patients transplanted.
Excellent. Thank you, Linda. I hope you all can hear me. Dr. Givers, thank you. That was an excellent presentation review of, the history of heart transplantation, and a great segue to a little bit of what I'll get into, but also share, how our partnership with individuals like Dr. Givers and his team are really paramount for the outcomes of transplantation. And as he shared, some of the innovations that are coming forward are really changing the way we operate as an organ procurement as well. So hopefully I'll give you all a little insight on how we operate as an organ procurement organization. As I share my screen, everybody okay? Can y'all see that? All right. So again, I guess I just start out by thanking, Linda and Hamid and Pat for having us as part of the session. I think, it's really a privilege to talk about what we do. I think a lot of what we do at times is sort of behind the scenes. But, I wanted to give you all an understanding and landscape of who we are. And really just, my slide's not advancing. There we go. So give you all an idea of what an actual organ procurement organization is. You hear the term OPO, especially in our field and within our hospitals, we use it a lot. But what we are, we're not-for-profit organizations. We're the organizations responsible for coordinating deceased organ donation and working closely with our transplant partners to assure that organs can safely be recovered and transplanted into potential recipients, such as some of you who may be waiting on this call or may have already received a transplant. Our role is pretty expansive as an organ procurement organization. We do a lot of education with our hospital partners. It's really that collaboration with hospitals that makes our work possible. And I'll talk a little bit more about that shortly. The other part of our role is assessing the suitability of a potential organ donor that is referred to us here in the New England region. And once the determination of suitability is made, we then either approach families and offer them the opportunity of organ donation or share with them that their loved one may have the opportunity to help through the organ registry or they're a registered organ donor. And so that obviously can be a complex process of a family going through a very, very difficult situation. Usually it can be a traumatic situation, but the legacy that can be given through organ donation really carries many families through this, knowing what the outcome can be of saving the lives of many individuals. So once we've authorized donation or moving forward with donation, our work really starts with collecting and conveying a lot of clinical information. This information is really essential to allow transplant centers to evaluate organs specific for their recipient. And I'll talk a little bit about what goes into that. And this is a very regulated process in the United States. There's a lot of policies and compliance metrics we have to follow to make sure at the end of the day organs are recovered safely, minimize any risk to potential recipients, and make sure they're transported safely to potential transplant centers, and working through some of the logistical challenges at times that occur through getting an organ from potentially one part of the country to another part of the country, from sometimes California to Maine, or California to the Boston area. And so we work collaboratively with many, many partners to make sure that happens. And lastly, I would just maybe state that New England Organ Bank, which we were formerly known as, we're now known as New England Donor Services. We were the first true organ procurement organization in the country. So, we've been doing this work here in the New England region for a long time. It was actually a collaboration of hospitals within the Boston area, including Brigham and Women's, who established the first quote unquote organ bank that really sort of was the foundation of organ procurement organizations. And we are one of just over 50 in the country and the only one that serves New England. Sort of a segue to my next slide here. So as Dr. Givert shared, we cover what we call Region 1. There's many regionally based organ procurement organizations throughout the country. We just so happen to be the only one for the New England region in Region 1 here. We have relationships with just over 200 hospitals. Within those hospitals are 14 transplant centers, and also within those centers are sometimes multiple programs. For instance, some of our partner hospitals have a heart transplant program, a liver transplant program, and possibly a renal transplant program. And so this partnership, as you'll hear throughout the rest of my talk this afternoon, really is really paramount to the work that we do. And just to add, believe it or not, we do cover the island of Bermuda. We do go down and coordinate donation, I'd say on average once a year in the island of Bermuda. It's certainly a unique experience, but definitely we've been able to honor wishes of individuals on that island over the years, and been able to bring organs back, typically in most cases to the New England region, or sometimes, depending on logistics, other parts of the country, and they are successfully transplanted. So a little unique for our region, but our organ procurement organization covers that area as well. So very generally, I could get into so much complex detail about, the relationships necessary for organ donation, and the process of getting to transplantation and how that works. But really it is the collaboration of these four pillars here: donor family, obviously likely going through the most difficult time of their life, making a decision for their loved one to be an organ donor, or honoring their loved one's decision, as I said, as a registered organ donor. We couldn't do that without the donor hospital. So as I said, there's just under 200 hospitals that we have partnerships here within New England. There could be a potential donor at any single one of them at any time, night or day, 24/7. This is something that happens operationally around the clock. And so the donor hospital, the donor family, of course, the OPO and NEDS, and then our transplant surgeons and the transplant team that is considering the organs for transplant and evaluating the information that we provide to them are such an imperative part of this process. So, there's a lot more that sort of goes in between all of these sort of main pillars, and a lot of work that happens really behind the scenes, with partners in logistics, partners within our hospital who help do some of the testing, which I'll review, to evaluate organ donation. But really is probably one of the biggest collaborations that I've ever been a part of in healthcare. So I thought this was a unique way to really look at it. And I know it's probably random to see a slide of the MBTA transit system here in this part of my talk. But as I was preparing for this, I came across a very interesting map that looks very much like this. And so if you look at the MBTA, there's sort of, segues and different pathways that all come together sort of in a central place or to a central point. And so if you look at the transplant system per se, it looks very much like a transit system. There's a lot of things here in some detail, but as you can see here, it sort of begins with, a patient waiting for a heart transplant, and all of the work that goes in there, seeking a center that may take you and evaluate you for potential heart transplantation. How is that, I know there's been some talks about, paying for all of this and some of the insurance coverage. And so if you go along the transit line, there's a lot of different pathways that you really need to go down and can go down in order to evaluate your failing organ. As you can see up here, is a spin-off or sort of a pathway to organ procurement, which includes the donor hospital, the potential donor in the hospital, authorizing sort of a donor family down here, the offer organ, and we can say, for instance, a heart being offered to a transplant center, the recovery part. There are times, unfortunately, where we go into organ recovery and the organ may not be healthy enough on visualization, or we may find something intraoperatively in the organ donor that may preclude donation from happening. We do a lot of work up front, as you'll see, to make sure that there's no risk in these organs being offered and transplanted, but there are times where we do get to organ recovery and there's something that can be found that may not allow us to proceed forward with actual organ recovery or transplantation. So there's a spin-off there. But as you go down this pathway, some of the R work, you sort of go back down into the, and I apologize, my arrow really isn't working here. There's the organ offer to the patient, the actual transplant, and then there's this whole spin-off of caring for a family and the work that we do post-organ donor. We care for that donor family for a long period of time. And in fact, some of them become real good advocates for us. So I thought this was just a really good visual to kind of look at sort of the pathway, not only from the OPO perspective, but the entire process of what someone may go through to either get to transplant or, and where we fit in the sort of the process. So I'll sort of shift gears a little bit. As I shared, a lot of the work we do requires a strong partnership with hospitals. And so the first part of the work that happens is a referral is made on a patient who may not likely survive their hospital stay. And our work is then evaluating that potential patient for potential organ donation. And, in general, the numbers are extremely small. It's extremely rare that someone can move forward to be an organ donor. Current statistics really currently in the United States, less than 1% of individuals die in a manner to be able to be an organ donor. It really is a very unique opportunity for somebody to help someone through deceased organ donation. And so once we've determined that someone is eligible, we do a lot of initial testing, and we have to do that in collaboration with our hospital partners. And specifically to the heart, we do a lot of work evaluating, blood work, cardiac enzymes, EKGs, and I believe that's my next slide here, echocardiograms. In some cases, depending on certain circumstances, a cardiac catheterization needs to be performed on the donor to make sure the coronary arteries are patent. And all of this information is provided to individuals such as Dr. Giverts and his team to make an evaluation. Is this heart going to be the right heart for my potential recipient? Is it the right size? And so our job as an organ procurement organization is essentially to provide as much information as we can so our transplant partners can make the best decision for their recipient. And so we may do other testing above and beyond what's here. We definitely do a lot of blood work. We also do, as Dr. Giverts mentioned, hepatitis C and transplantation has really evolved over the last few years. And the treatment options available for recipients it really has changed our ability to offer these organs to transplant centers. So we do a lot of testing for viral disease, hepatitis being one of them, HIV. So all that work is done up front to make sure we, again, can provide that transplant center with all the necessary information to make a very important decision for their recipient. And so as I shift gears a little bit more, a lot of that information is collected and put into a very big database. And I think we get many questions on, how is all that information, shared with transplant centers? How does it get there? How do they have the ability to see it? And so we're fortunate enough to have really great technology today. I will say many, many years ago, it was a literal phone call to the transplant surgeon, giving them information over the phone. When I started here, we actually faxed a lot of information. And so thankfully, technology has really evolved over the last few years to allow us to get information right in front of providers and the transplant centers in a very direct way. So they're able to view imaging, they're able to view echocardiograms, they're able to view EKGs right in pretty much real time and evaluate that donor heart really like if they're right at the hospital looking at this patient. And that really is essential to, again, making sure the right organ is selected for the recipient. And so all of this is really done in collaboration with our partners at UNOS. UNOS is the United Network for Organ Sharing. They are essentially the center of organ allocation. They generate lists for organ allocation, and they maintain a very big database of all donor information that all of our transplant partners throughout the country have access to evaluate. So all of the information we obtain from the donor, the lab work, the imaging, the x-rays, or whatever else we may need to share with the transplant center is uploaded into the system. Today they're actually able to view it on their mobile device in most cases. So it's, again, really very, very accessible at any time of the day. Because like I said, donation happens at any time of the day, 24/7. We make organ offers, 6 a.m., midnight, 2 a.m. to many, many of our partner hospitals, depending on, where we are in the donor workup process. And so at the end, once all this information is uploaded, at any given time, a list is generated, and that list changes, continuously by the minute. There are individuals taken off There are individuals added, there are individuals that are elevated on the list for different reasons, and I'll get into that in a moment. But basically that offer can be reviewed, and the transplant center will able, decline the organ offer or accept the organ offer, depending on, the specificity and decision by the team, based on their recipient. There are many reasons we could certainly talk about on why an organ may be right for a potential patient. And it may be a given day, it could be the size of the organ, it could be, the recipient is too sick to receive the organ at this time. And so there are a lot of factors that go into that. And so, I sort of talked about this already, but blood type and body size and time waiting and degree illness are all the factors as to why individuals are listed, in certain spots on the list. And I found this to be also a little bit helpful, and hopefully something that may be helpful to some on this call. Looking at all organs as, there's many reasons on why individuals are listed where they are on the transplant list. There's a tremendous amount of factor that go into it. So focusing on the heart, given the individuals on this call, your medical urgency. So if you're in the hospital sitting, on an LVAD or on ECMO, that may increase your medical urgency and need for transplantation, depending on the scenario. Distance from the donor hospital. Pediatric patients, again, may hold a slightly different status depending on their severity of illness. So every organ really there's a lot of criteria that goes into where you may sit on the list, and that may change throughout the course of your treatment. So, if you're at home doing well on heart failure therapy, as Dr. Givert shared, you may be, still waiting for heart transplant, but may not be as high on the list as if there were somebody in the hospital, waiting for more urgently for a heart transplant. And so that list does change. We run a list basically at the time we're ready to set an operating room time within about an 8 to 10 hour period. And so there are times where if we are unable to set, an operating room recovery time in a manner that satisfies, all our donor hospitals, or recipient hospitals' needs, or we sort of have spent an inordinate amount of time evaluating the donor, we may have to rerun a list to make sure there's no medically complex patients who moved up urgently on the list. And so, again, a lot of factors that go into the allocation piece of the work that we do. And so really, that's kind of where I'm going to stop here, with hopes that there are some questions. Like I said, the organ procurement process and our role is very complex, but it really is necessary to have a strong partnership with our transplant partners, our donor hospitals, for all this to happen. And it certainly can't lose sight that many sitting here, it's a difficult topic to talk about, because at this point, Dr. Givert's talked about xenotransplantation and the future of organ donation and the potential of transplantation utilizing, animal organs. That is part of the vision we work with our partners on. But I will say it is also hard for many to sit here realizing that somebody does have to lose their life in order for you to live further on. And the difficulty of that, and I've seen it firsthand in the work that we do, and the emotions that are part of that are not lost on us. And so the more we can utilize technology and advanced therapies and look at fields like xenotransplantation, I think are really going to be important as we move forward in the future of organ donation and transplantation. So thank you, and certainly welcome to entertain questions.
Greg, thank you so much for that fantastic talk. And I have to say, they say a picture is worth 1,000 words, and that comparison to the transit system really rings true and clearly shows how complicated this journey is for transplant for patients, both from the hospital, donor side as well as donor services side. So, you know, it's always hard to explain that to patients who are waiting so long. What I'd like to do is just, I'm going to throw this question out, and either or both of you and or Dr. Givers could answer this. You know, historically, patients in Region 1, which is what we are, have had longer wait times than other areas across the nation. And how has this changed over recent years? And, you know, if so, if it has changed, what do you attribute that to? What are the factors that has potentially helped patients in our region get transplants sooner?
I think Dr. Givers might be on mute.
Craig, you want to jump in first?
Yeah, no, happy to. I saw you talking. So yeah, excellent question, Linda. And I think, you know, there's a lot of factors. I think historically, you know, number one, there has been a lot of changes in the allocation system, the way organs have allocated, even just recently in the last, you know, year. And there's going to continue to be evaluation on how organs are placed within not only Region 1, but other parts of the country. You know, as far as seeing an increase, and I was actually just looking at the number of hearts we've recovered here in Region 1 just before this call, we definitely have seen an increase in the number of hearts recovered and also offered in the region. And I think, you know, Dr. Givers had mentioned a little bit, but hepatitis being one of them, the overdose epidemic here in the Northeast, you know, it is hard to pinpoint, you know, whether there's sort of the work that we do as an OPO, the types of patients that die in the manner, not only for organ donation, but for even heart transplantation or to evaluate the heart, has evolved. And I think with machine perfusion and technology, with the advancements of utilizing hearts with, you know, disease and hepatitis, I will also say our advancement as an OPO, we are looking at donors now that we did not consider 2 or 3 years ago. Donors that with, you know, potential active infection, working with our transplant partners here, we're able to evaluate these donors. So we are increasing the number of donors we're evaluating for heart transplantation. I will say there's still, I think, some complexity around how organs are offered and distributed, not only here in the Northeast, but throughout the rest of our country. Definitely another conversation that can certainly get a little deep, but I would say with strong partnerships with our transplant centers who are accepting these organs that we're offering with a little more complex history and a little, maybe, you know, for instance, we have recovered hearts recently with a small amount of coronary artery disease that are being considered. And that to me is really changing the landscape of organs available and the organ donors that we're pursuing as an OPO.
Yeah, I would just add on the patient side, you know, in my experience, and Linda, I'm sure you can attest to this as well, the patients that are being, that are going onto the waiting list currently, they're sicker than they used to be. Patients are sicker, they're in the hospital, they're receiving care in an intensive care unit. And so their priority is higher than it used to be. I think when we got into this field, when I got into this field, it was more common for patients to be waiting at home for their heart transplant. They were taking pills. We would call them in from home. It was I always loved making that phone call. I'd always say, "Are you sitting down? Is there anyone with you?" And then I would give them the good news. That's not common anymore. Patients, because of the way hearts are offered, the way the system changed a few years ago, generally patients have to be sicker to get to transplant. But the good news is that with the newer system, we are getting those sick patients to transplant more quickly. The only other point I would make is that I did point out that new technology, and I skipped over the slide that actually showed you the heart beating in the box or in the system, but that's allowed us now to go farther to get donor hearts. So our surgeons and people who work with our surgeons can now go well beyond what was 500 miles or 800 miles, and they're going to Chicago, and they're going as far away as Phoenix to bring hearts back to New England. And I know, Craig, you didn't talk specifically about that, but hearts are not only coming from within, but without of the region. So we have sicker patients, we have hearts coming from farther away. And so the waiting times are shorter, but it means that it's the sicker patients who are appropriately, I think, moving more quickly to transplant. There was one question in the chat box, but I don't know, Linda, if you saw it, that I wasn't sure. It says, what are some of the reasons a heart transplant would be called last minute? Maybe the person could clarify that. I'm not sure if I understand what the question is, but Linda or
Yeah, I wasn't quite sure either. Yeah, if
was
the
Don
person
Mitchell.
could just clarify a little bit, or Pat, do you know what?
It was Don Mitchell.
Yeah, I know it was Don. Yeah, maybe if Don can just clarify. He just said, right, exactly, called last minute while the recipient is in or waiting in the operating room. So I wasn't quite sure about that. I wasn't clear if that was potentially, sometimes, you know, transplants don't happen. Patients are in the operating room and, you know, the transplant might not happen because.
what did he mean called off? Yeah, go ahead.
Yeah, maybe he means called off. I'm not sure. But I want to move on to a little bit about, we'll see if Dawn can clarify that question, but you know, what have been some of the concerns that patients have that prevent them from accepting something like, you know, a hepatitis C donor? As you talk about, you know, the changes that have come along that have actually opened up more organ availability for patients. Not everybody is signing up for that, correct? And what are some of the challenges with that, or what have you found that patients are concerned about?
Well, it's a difficult discussion to sometimes have with patients. We try to have this discussion well in advance of the transplant. You don't want to be calling a patient at home or coming into a patient's hospital room to say, you know, I have this wonderful news. We've identified a donor and the heart is perfect and you're up for this transplant. But there are these issues that we just want to discuss about the donor or the heart. So we tried to lay out some of those things in advance. You know, I've heard, I would say in 2023 now, most patients, once they understand the information around treatments that are available for example, hepatitis C, they make what I would say is a good decision, which is that, you know, their risk of saying no and wanting to sort of pass and let's wait a little bit longer and see if another heart becomes available, the risk of waiting, in my mind, typically far outweighs the risk of moving ahead. And there really is almost no risk now. I mean, there are a few things that we don't know about the long-term effects, perhaps, that an infection like hepatitis might have on the donor heart. But all of the information we have at this point now, we have several years worth of information, is that patients do just as well. There's absolutely no difference in short or long-term outcomes. So I would ask, you know, if you know someone who's not sure what they want to do, you know, they really should have that discussion with their nurse, their nurse practitioner, their physician, to really get more information, educate themselves about, you know, what they really need to know. And in the end, sure, if it's not the right decision for the patient, that's totally acceptable to us. And ultimately the patient makes the decision and we'll go by that.
Thank you, Dr. Givers. Our attendee, Dawn, had clarified. So this was a case that he was in the operating room, intubated, and the transplant got called off. So he's asking, what are some of the reasons that this could happen? Because we know that it does happen. It doesn't happen all that frequently, but frequently enough that we've all experienced that.
Yeah, I'm happy to jump in here a little bit. I think, you know, being, you know, part of the recovery process on our end from the OPO, obviously, as I shared, we do our best to share every piece of information with the donor, the recipient hospital and the transplant team to assure they have all the right information to evaluate, you know, heart specifically for their recipient. I will say there are some things that happen in the operating room during the recovery process. We may find something that could be, you know, honestly, potentially harmful or even malignant in the donor that we didn't know. That could lead us to stop the procurement, meaning that the organs may not be safe for transplantation. There are other times, you know, typically the recipient hospital sends a member of their transplant team out, or multiple members of their transplant team, to do the heart recovery. And during the visual evaluation of the heart, they may see something that just doesn't seem right or fit for their recipient. There's a lot of communication that occurs in the donor operating room and the recipient operating room, to make sure this heart, specific heart or organ is the right organ for their recipient. Sometimes it could be size related, even though, again, they have all the right information, until the actual visualization of the organ is really made. It's really suitability, from my perspective, is always being determined until the organ is actually visualized physically. And so there's many reasons. Sometimes there are, like I said, findings in the donor that we weren't aware of that might lead one to not take the risk to recover their heart for their recipient, depending on the situation.
Thank you, Craig.
And
I
in
just-
my experience, when that happens, I would say I've never had really a patient who was upset. Sometimes they realize, it's good news if the heart wasn't right, or if there was a problem with the heart in transport, and by the time they got to the hospital, the heart wasn't the way the surgeon really wanted it to be. They make the right decision for the patient, and for some patients, it just means that they're on deck. They know they're close to getting a transplant, and that's good news.
Pat, did you want to?
I can't ask, I can't type in because
That's okay.
could you talk a little bit, both of you, about DCD hearts and the influx of what that might do to change the numbers in a favorable manner?
Yeah, so I was going to mention that actually as part of the initial question. I think, we didn't get into the two types of organ donors that or two types of patients that leads to organ donation. But, in simple terms, we have beating heart donors and not heart beating donors. And so a pathway to donation, which we refer to as DCD, or donation after circulatory death, is we are actually waiting for an individual's heart to stop before you proceed to organ donation. I will say that, as Dr. Givert shared, the devices that are available now to allow organs to be placed on perfusion devices that allow reanimation of the heart after recovery has really increased the number of hearts that are available for transplantation. Now, I maybe let Dr. Givers get into the specifics, but I think, there are some different considerations, I think, for certain recipients related to DCD hearts that are recovered and perfused versus the beating heart or neurologically deceased donor heart. That it can be considered. But I will say that it has and will continue to increase the number of hearts that are available. In fact, here, just as more of a statistic this year, we are seeing more of the non-beating heart or DCD donors in our region this year than we ever have. And so we really have to increase and improve and utilize the technology that's available to be sure that we're recovering as many organs as possible to help those waiting.
Don't have a lot more to add, only to say that, I showed you that photograph of the first heart transplant that occurred. That was actually a DCD transplant. So I mentioned the young woman who was unfortunately killed in a motor vehicle accident. That was a donation after circulatory death. Now, we didn't do that, and nowhere was that done in the world for the next 40 years until really investigators and really, I think, bold teams starting in England and in Australia, and now really around the world are taking on this form of transplantation. The donors themselves typically are not that different, but the mode to organ procurement is a little bit different. And we're learning a lot about, and I will say, others on the call may have also, I just got back from Denver at the International Society for Heart and Lung Transplant meetings, and there was a lot of data presented. And the good news is that the outcomes are the same. There's essentially no difference between whether a heart comes from a donor after circulatory death or what we call a donor after brain death. The outcomes are similar and excellent in both cases. So I think we don't need to worry, at least at this point, that and particularly the recipient should worry that they got this type of donor or this type of donor. I think everyone who's doing this now knows how to do it, and it's working out just as well as the way it's been done for 30, 40 years.
Do you have to notify if it's a DCD heart?
It's not part of research anymore, Pat. So,
Okay.
so basically, when we consent patients for listing for transplant, I think most programs now say, give some very basic information about, this, it could be one of these two different types of donors. And as you know, and as many people on the call know, we don't give out any specific information about the donor. We are required to tell recipients that if it's a donor that is considered a donor of increased risk, that's determined by the Centers for Disease Control based on a number of factors that we didn't get into. That is required information that the recipient and the recipient's family has access to. But other specifics about the donor, as you know, is anonymous. We always encourage our patients, Linda can speak to this as well, Craig, to, if they feel like they would like to reach out to the donor family through the New England Donor Services by writing a letter or sending a card. And sometimes the donor family at some point will reach back to the recipient and the recipient's family. And we've all had instances where the patients met the donor family and have become very close to the donor family. It's amazing when that happens.
Mead's one of those. I was one of the ones, Linda was in the room when they had to ask me about, it's an abnormal heart. And my first question was, what does that mean? But that was 10 and a half years ago. So I was just curious as to if things changed or how they changed. But
Great question.
Linda was in the room when they said that, and it was once the surgeon told me looks great, I was fine with it. So I think
Right.
I would hope that most patients would choose that if the surgeons have agreed and get on with it, because you never know when that next one is.
That's correct. I just want to be respectful to our speakers. We are over by 10 minutes. I have, one other question, but if people want to continue on, or if we should close it for the day.
I'm flexible if you have another question.
Okay. Well, I think that the last question is really more about, patients are living longer after transplant, and what are the key factors? What do you think of the key factors contributing to this success, both from the medical side of treatments and strategies on the patient side of things, of the coin? Because we all know that plays a large role as well.
I can jump in, and then I'd actually be curious to hear from others. Linda, I'm sure you can comment. Pat, I mean, you might comment as well. I think certainly the patient plays a large role in that, right? So patients who take good care of themselves and are adherent to all the things that they need to do to take excellent care of themselves and their heart is really key to success. As far as changes in the field, the successes are slow. I'm going to be honest. If I showed you trends over decades, yes, things have gotten better, but they're not dramatic. I mean, I showed you the outcomes. I showed you that more than 50% of patients are living past 10 years. That didn't look that different 10 years ago. So we haven't made huge strides. And in fact, one of the constant messages that we try to get across at our national and international meetings is we need to learn more. We have all of these patients that we're taking care of that are living with heart transplants. We need to do more clinical investigation studies. We need to determine what are the best medicines for patients like yourselves on this call to really promote long-term excellent health. We are fantastic at doing that in the field of coronary artery disease and heart failure. We don't do it that well in heart transplantation, in part because every center does things a little bit differently. So Tufts and the Brigham and Mass General and Children's and Hartford and Yale New Haven, these are all centers in Region 1. I'm sure we could not get in a room and agree to how we manage our heart transplant patients, but all of our patients do equally well. So that's part of it. I think we need to have more consensus around our care, but In terms of, immunosuppression, preventing rejection, antimicrobial therapy to prevent infection or treat infection, and then some of the treatments that we use to slow the progression of the coronary artery disease I mentioned, these are key. I didn't say much about malignancy after transplant. Patients who are on immunosuppressive medications for many years are at risk, particularly of skin cancer, basal cell cancer, squamous cell cancer. We need better treatments, and we really need better prevention strategies for our patients. So there's still a huge amount of work to do in the care of patients following their heart transplant. And I really would look forward to us working hard at trying to answer some of these questions and really make bend that curve even greater in terms of long-term survival.
Craig, do you have anything to offer on that?
Yeah, I mean, I would say, not so much on the donor side. I think it's hard, that from the OPO and donor side, I mean, I think, we're really faced with, it's very unpredictable what type of patient will become an organ donor. And I think, I will say from our perspective, we do a lot of work and actually work with some of our partner transplant centers and cardiologists to talk about how we can enhance and improve heart function to make these hearts potentially transplantable. It's really hard, obviously, to change the chronic medical history that may be associated with a potential donor. But I will say that there's a lot of effort on our part to make sure we can, do everything we can to optimize the heart for the potential recipient and the need of their recipient, whether that's different medication therapy, whether that's diuresis, whether that's, many sort of donor management strategies that we employ in many cases, if in fact we are evaluating a heart for transplantation.
Well, I want to thank you both so much, Dr. Giverts and Craig, for the fantastic talks that you've given and the discussion and how and answering the questions from both the audience as well as some that were just mine. It's been a pleasure working with you. I'm going to hand this back over to Hamid. Oh, you're on mute. There we go.
Okay, I can't say thank you enough on behalf of Heart Brothers, myself as a patient. This was phenomenal. And we're definitely going to be counting on all three of you and your talents in the years to come to help educate our patient community, because that's what we try to do and try to serve the patients. And to the patients, thanks for joining. Thanks for listening. If Heart Brothers can be of any service to you, please reach out to us. Just go to our website, and we're here to serve you, to support you and make your journey a little bit easier. Thank you. With that, I will end the call and thank you again.
Thank
So
you,
much.
everyone.
Thank you.
Take care, guys. Have a nice night.
Take care all.